Dr. Manju. I invite our next speaker, Dr. Shaji Hussain. Dr. Shaji is a cataract and refractive surgeon practicing at Abate Eye Hospital, Perinthal, and also he visits the Calicut Center. His topic will be cataract surgery in a compromised cornea.
Good morning, everyone. As you can see, the topic is about how to go about with cataract if you have a compromised cornea. So, to begin with, the four main things wherein you have a compromised cornea before doing a cataract surgery, most of us would be facing a keratoplasty patient, a patient who has already undergone a refractive surgery, who is having fuchs endothelial dystrophy and keratoconus. So the first thing to strike in keratoplasty is about the sutures. Remove the sutures, wait for 3 months, and then go about and go with your biometry. Refractive surgery, the two main concerns are which formula to apply and what IOL type to be placed in. In fuchs endothelial dystrophy, it's definitely the grade and the count of the endothelium cells that's important. And in keratoconus, how smooth the cornea is. So to begin with, as I said, keratoplasty, remove the sutures, do the biometry. If it's already a hard cataract you're dealing with, better to go about with this small incision cataract surgery because less trauma to the endothelium. Now, let's say you are going ahead with in early stages. Usually, keratoplasty cataract is usually the patients are on steroids and the patient may be having usually most commonly PSC. So you're usually dealing with a soft cataracts initially. And here, definitely it is the endothelial protection that has to be kept in mind. So you do quite and you have to use the dispersive visco. Make sure the rexus is well controlled. You can't afford to have an extension here because as such the endothelial counts and much of manipulations we have to be very careful here. Do a controlled rexus, and then by making the incision, make sure you are not involving the graft host junction. If you are a beginner, you can always go with a sclerocorneal incision. And ensure you have a good, and when you're using the phaco, ensure you're using it in a low power mode. And next is to dealing with keratoconus. You have, as I said, you have to deal with the see how smooth the cornea is and in what stage of keratoconus you're doing the cataract surgery. So in that, it is the formula that I'll be dealing with later. And the IOL, you can ideally speaking safer to go about with the spherical, but you have now toric and even high toric lenses that can be customized. Ideally, the available toric powers would be -6 cylinders, but if you can customize it, as in the previous speaker said, even up to 14 diopters and all can be after customizing it. So the con position, if it's central, you can go about easily, but if you have a decentered, then you have to counsel the patient accordingly. And post-surgery vision, you can never guarantee a 6/6 vision. It always depends on how much the patient will be seeing post-operatively only. And even while doing the surgery, the view is something you have to look at because you may have excessive reflexes from the thin cone. If you are already dealing with a patient who is having an advanced keratoconus, it's ideal to go about with DALC and then do the suture removal, wait for 3 months and then plan the cataract surgery later. If the patient develops a cataract later. If you already have an advanced keratoconus with opacity, you can even plan a triple procedure. With regard to the IOL, the standard approach is if you go about with the normal formulas, there are high chances you can end up the patient in hyperopic surprise. And usually the patients prefer after cataract surgery, it will be better to target a myopic power. So if you are dealing with a mild to moderate KC, you can always go about the SRK-T and keep a target myopia of -1 to -2 to be on the safer side. But if you are already dealing with a severe KC and you don't know what would be K would be, plan an SRK-T with a standard K of 43.25. And also now the Kane KC, Barrett True KC are all giving promising results, but it cannot be yet conclusively evidenced and not yet confirmed. So what is refractive surgery got to do with the formula? Here the main two things you're dealing with is the compromised anterior corneal curvature, and you know when a variation would result in a 1 diopter IOL, and the prediction, the difficulty in predicting what would be the effective lens position would be. So if you go about, usually if it's a myopic patient who has undergone a refractive surgery, you can always end up predicting a hyperopic shift. So the instrument error here would be in a post-refractive surgery, it is only the central zone that is being estimated, and even in the central zone in a post-refractive patient, you have different curvatures at different points. And the machine will be calculating it at 3.2 millimeters, but at the central areas, the curvatures are quite different. So again, you will be, in a myope, you will be underestimating the power and making him hyperopic. So what is all the trouble here is the refractive index being considered in all the IOL formulas it is 1.337. But that this in a curvature, normal curvature, that is fine. But here in a post-refractive patient, it is flattened surface anteriorly, and this relationship of refractive index of 1.337 is no longer standing. And hence, there are various formulas that are available, and the things that is gaining importance is the equivalent K reading that can be calculated in the pentacam. And here it is actually the 4.5 area and the EKR65 mean that is usually taken up as the K value. So the formula error, again, it will the effective lens position would be wrongly calculated to be positioned more anteriorly in the formula if you are not keeping this in mind. And there are a lot of other formulas that can be kept. So the main thing here, or the easier way out, would be to use the ASCRS calculator. This is the website that you can go into, enter the values, and give your patient details, and the formulas will just be given, and you can always go for the average IOL power or the maximum. So the question is about premium IOLs, can it be implanted? See, it always depends upon how it should be a well-centered ablation. There should not be an excessive higher order aberrations present, and it should be in the latest generation of refractive machines that the patient has undergone. Then yes, there are thoughts about placing extended EDOF lenses, and even this Synergy platform lenses. So in conclusion, always make sure the premium IOLs consideration has to be, if you're a starter, it's always good to go about with the single vision distant lenses. And the next question would be about fuchs endothelial dystrophy, and here the question is whether I should be planning phaco emulsification alone, or should I be combining it with an endothelial keratoplasty? Well, to consider that, it would be always better if you have suboptimal endothelium with cataract. Phaco emulsification can be considered, and then plan a second stage endothelial keratoplasty. The next thing would be, when do I go about with a triple procedure? I can plan DSEC with phaco, or I can plan PKP with ECCE. Now, what are the three things to be considered here is the PACI has to be according to the relationship with the thickness of 650 microns. I'll tell you when and how good the view is for the surgeon, and how is the endothelial count. Is it above 1000 or not? So in fuchs endothelial dystrophy, if you are looking at a thickness that is less than 650 with a good endothelial count, you can go about with phaco alone, but the counseling has to be done well, that the patient may need a endothelial keratoplasty at a later stage. Now, if it is 650 less than 650 with cell count of less than 800, then you have to be in the second level of counseling for the patient, that he may need it very soon. And if you're already dealing with a thick cornea that is more than 650 microns and the cell count of that is less than 800, then it's always ideal to go about with both together. So this is again just as we did in a PKP, we have to take care about the endothelial count. And the other conditions where you may have trouble is you have central corneal opacity with cataract. You can plan a triple procedure. If you are looking at a dry eye, always treat the dry eye first. Otherwise, you will end up with patients who will keep eating your head. And if you have a service problem like a pterygium, I always do the pterygium first, wait at least for 6 weeks, and then plan my biometry. Herpetic keratitis, you will have to cover the patient on antiviral drugs, wait for at least 2 to 3 weeks, and then monitor the patient even post-operatively. Bell's palsy, exposure keratopathy is one thing you have to keep in mind, and ensure you may have to do a tarsorrhaphy if the eyelids are not closing fast. And in immune keratitis, it's always ideal to do the cataract surgery under steroid cover. With that, I thank you all for your patient listening.
Thank you, Dr. Shaji. As we are running out of time and Dr. Shaji has a session next, I think we can take the question.